Okay, thanks everybody for joining us today for virtual grand rounds sharing Prognosis. Just going to share my screen. This is sponsored by the Palliative Care Committee, and I just like to introduce myself. I'm Rachel Morris, and I work in Milwaukee at the Medical College of Wisconsin. And joining me are Dr. Joyce from Yale and Dr. Cook at OHSU. So thank you so much. Today, we're going to be talking about a prognostic discordance, and this occurs when there's some sort of disconnect between patient, families, and providers on goal concordant care. So matching the patient's prognosis to what we expect that the patient is going to be able to get back to from a functional or from a mortality standpoint. And this can create a lot of tension in the family and provider relationship, as well as a lot of distress. What percentage of surrogates express doubts about our ability to prognosticate in critically ill patients? So really high, 88% express doubts, and approximately 50% express an optimistic prognosis. What information do surrogates use to prognosticate? So reasons for prognostication include the patient's appearance. 36% stated the power of optimism, intuition, or faith. 30% unique or intrinsic qualities of their loved ones. At 28% previous track records, such as, my loved one has been through this before and did well. 13% power of bedside presence, and 4% belief in miracles. So these are all factors that influence surrogate decision makers in the perception of prognosis. And it can be really interesting to talk to patients and families and figure out, what their reasons for prognostication are in a specific case. And as you can see, there's a lot to take into account and can be highly variable in different patient and family circumstances. And less than 2% in this study relied only on the MD's prognostic estimate. So there's a lot going into how families feel their loved ones may do after an injury. So how do surrogates prognosticate? Who is your main source of information? This was looked at in the Journal of Critical Care in 2014. 75% identified the nurse, 25% reported at least one consistent message, and of these, 38.7% reported that this happened multiple times. So going into a family meeting, discussing things like prognosis and ways to care for the patient ongoing, it's good to know that a lot of people are bringing this sort of mixed messages into that family meeting. So 74% said this occurred within the first 48 hours of the ICU stay. What is the process versus outcome logic? So this is a perspective article, The Debt of Life, TIE Lessons on the Process of on a process-oriented ethical logic. And one interesting statement that was quoted: the daughter refuses to hear prognosis, concluded my attending. It's classic. She listens, but she doesn't hear. The chance of a good outcome is 0. We're flogging this man with feudal medicine. She's hoping for a miracle. So a great example of prognostic discord, the attending feeling like the family is not hearing the prognosis that's given, and not understanding the perspective of the family is bringing to that conversation. And hoping for a miracle, I think, can be one of the more challenging aspects of prognostic conversations. So when you're wondering if you have prognostic discordance going on in their situation, There's some examples of what you hear. For example, we heard, I don't understand, what do you mean? As an outcome versus a process, and some communication skills or strategies that can help are to ask, understand, reframe, and give a headline as an example. And I'll talk a little bit more about what exactly a headline means in this context in ask and tell. And then another example being how to deal with a grief prognostic discordance. What you hear might be, I can't believe this is my fault, I can't lose them. And one way to respond might be to use a nurse technique, which we'll discuss, and respond to emotions can be helpful to deal with through an interprofessional team. So next, to go on to some practical tips to reduce discordance and distress. And as I mentioned earlier, one way to help is to use the headline technique, and this is discussed in Vital Talks. And headline describes using a statement at the beginning of a conversation that's summarizing and emphasizes the impact of what you're trying to say. So thinking about if you're reading the newspaper, it's unlikely to say 5 Democrats fought with 5 Republicans and ended up in a vote of 10-21, resulting in a bill that was discussed for 3 hours that passed. It'll be something more like 5 million people lose their jobs due to X. So that's an example of a headline, which can be a helpful technique when discussing prognosis with families, that they are unlikely to hear a lot of details and be able to absorb them just due to the high stress involving these situations. And similarly, physicians may go into a lot of details that are not understandable to patients and families, trying to soften the blow, or maybe due to just some nerves on their own part, and can end up diluting the message for patients and families. So an example of effective messaging that might include, this means we are worried that your father is dying. So sharing your worry with a headline. And information to support this could be, for an example, your father's heart, kidneys, and lungs are shutting down despite the best of our treatment. And when in doubt, respond to emotion. So if a patient responds to your headline with sadness or anger, the most helpful thing is to respond with an emotion over logic, and responding with emotion to an emotion helps the provider and family be on the same team. So when you look at family support interventions, this diagram is just really meant to show that over the course of a week, providing emotional support or attending to the emotional needs of the patient and family are really necessary at every step. So how do you respond to an emotion? One acronym that's helpful is to name, understand, respect, support, and explore, or nurse. And I have some examples. So for example, of a nurse statement for articulating empathy might include naming, it sounds like you are frustrated. In general, turn down the intensity of a notch when you name the emotion. So don't get frustrated in response. I did try this with my daughter the other day when she was frustrated, and she said, great, you restated what I'm feeling. So it didn't work that well in that instance, but I think can be helpful to acknowledge and to make families feel heard. Other examples include, this helps me understand what you are thinking. I can see you really have been trying to follow our instructions, as an example of respect. I will do my best to make sure you have what you need, as a supportive statement. And could you say more about what you mean when you say that, to explore? So now we're going to turn things over to Dr. Cook, who will discuss prognosis and goals in the pediatric population.
Great, thank you very much. There we go. I hope I have done this successfully. So my name is Matt Cook, and I'm going to talk a little bit about how do we provide prognosis, how do we discuss goals in patients, our trauma patients who otherwise weren't anticipated to be at the end of their life, right? This is, we frame prognostication and goal setting frequently in people who are chronologically more elderly, who are more frail. And I think a lot of times those discussions extend discussions that are happening prior to their injury, namely, as you come to the twilight of your life, what does quality look like? However, children, teens, and young adults are just as likely to be injured, are just as likely to be a trauma patient as folks who are elderly. And it is vastly more difficult to get a sense on how we should talk about goals of care, how we should discuss prognosis, and how we should support our surrogate decision makers in these settings. So I'm going to talk here about the younger trauma patient. And in this mind, I'm going to lump together children, teens, and to a certain extent, young adults, people in their early 20s, people in their mid 20s, because I think there's a lot of similarities here. Namely, there's not a ton of data on how to talk to these younger trauma patients about their injury, how to discuss prognosis, how to actually make a prognosis. There's far fewer clinical calculators for trying to predict mortality than in older patients. And there's a lot more prognostic uncertainty. I think we all know that younger trauma patients, particularly with traumatic brain injury, really, but with many injuries, their recovery and rehabilitation potential is much, much greater than our older or more frail trauma patients. And so our ability to make prognostications about not only what does tomorrow look like, but what does next week look like, but what does 30 years look like is much more limited. 30, if we were to be looking in the late 1990s and try to prognosticate the support systems that were available in the 2020s, we'd be wrong a fair bit of the time. And that's true for our young trauma patients. The support systems, the rehabilitations, the future discoveries in medicine are likely to be significant. And then there's a lot more emotional and social distress that we need to manage, navigate, and support our patients and their families through. For better or for worse, people who are coming to the end of their chronological life, there is an expectation that the end of their life is near, regardless of whether or not that's today, tomorrow, or next year. But that expectation is not there for children, teens, and young adults. Many people are living their lives with their children or their teenagers or their young adult family members and anticipating that they have years and decades in the future to spend together. And it all of a sudden pivoting to a discussion about goals of care, about discussing prognosis, about future limitations is very emotionally challenging for people to navigate, both families and providers. So how do we work through that? Well, I think it is important to emphasize the difference between consent and assent, particularly in children and in teenagers, and there is some variation here on a state level. The appropriate surrogate decision maker is probably the parents, and if it's not the parents, hopefully it's clarified in an existing legal document. However, as children get older, right, it is important to engage them as much as possible in decision-making processes, because even if they're not the decision maker, right, a 13-year-old is maybe not the legal decision maker for themselves, it is important to get their assent to the plan and engagement with that plan. So those of us who are on the adult trauma side probably conceptually know this, but have to live that, and we don't actually have to live that line frequently. Folks who are frequently practicing in pediatric realm, I think, see that frequently. And as a distinction from some of our chronologically older trauma patients who may or hopefully have some sort of advanced care planning document, or hopefully have discussed some sort of advanced care planning with their family members, this is functionally never present in the younger trauma patient, right? There's just no reason why a 12-year-old should be discussing their end of life wishes with their parents. If that happened, I would be concerned in most circumstances. And so we're oftentimes picking up and helping navigate discussions that are starting at step 0. We're not even at step 1, but it's step 0. And as I mentioned before, there's not a ton of data. I will acknowledge here in a second, there are some differences and there are some similarities between children and adults, but there's very little data about the injured pediatric trauma patient, the injured teenager, or the injured young adult patient. There's a fairly large amount of data on pediatric palliative care in the oncology setting. But pediatric palliative care, discussing goals of care, supporting patients and their families through prognostic uncertainty in the cancer setting is very different than the trauma setting. And so we're forced to reason from some of our principles in the adult setting and some of our principles in the pediatric cancer setting. And there are some common sense recommendations. One is that the best case, worst case communication tool almost certainly will still work. This is a snapshot from the Patient Preferences Project, which is based out of the University of Wisconsin. I am not involved directly with, other than I think it is perhaps one of the best ways to discuss prognostic uncertainty with patients and their families and drill it into my residents' heads on a daily basis. But that communication tool probably still works. It might need to be adjusted for some certain, for a 12-year-old or for an 18-year-old, but the overall framework probably still makes sense in the pediatric setting. Early consultation with palliative care is probably even more important for pediatric patients, for young adults who are severely injured or who you're struggling with prognostic uncertainty. For all of those reasons I just mentioned, you're starting from step 0. You're asking patients and family members to process what does the next 30 or 40 or 50 years of their life potentially look like. And while we are capable physicians and we are well versed in primary palliative care, these are really difficult conversations, and engaging subspecialty palliative care, specifically pediatric palliative care, is probably even more important than in the adult world. And then the last one is early consultation with child life specialists. These folks truly are gifted both in engaging the patient or in engaging siblings. So one feature that is really different about young trauma patients, children, teenagers, young adults, is that their home life frequently includes siblings, and that their parents frequently are responsible for breaking this news to their siblings. And so the prognostic uncertainty that you're dealing with is not only at the bedside with the patient and communicating that with the surrogate decision makers, who potentially are the parents, but also helping coach the parents through how they're going to discuss that with also pediatrically aged siblings, and supporting them through that discussion. So pediatric palliative care and pediatric child life specialists are essential. Now, these recommendations really closely mirror the TCRIP guidelines on this point, and they do make a specific, the TCRIP guidelines do call out specific considerations for pediatric patients, which are very similar to what we talked about, and also very similar to adult palliative care. They acknowledge there's no data, and do suggest that in the same way that there's benefit to early palliative care consultation in adults, there's probably an early benefit in children as well to help us navigate some of this prognostic uncertainty. So pediatric palliative care, you've got a patient who's badly injured, they're young, they're early in their chronologic age, and you have to navigate that prognostic uncertainty with the patient or their family members or their surrogate, and you need to help them coach their siblings, the patient's siblings, through that. Well, pediatric palliative care is just like adult palliative care. Excuse me, my brother-in-law is a pediatrician, and he would probably have a stroke if I heard me ever say children are like adults, but in some ways they are. Palliative care, particularly pediatric palliative care, may only be available at specialized centers. It needs to proceed in parallel with recovery-focused care. Just because we're engaging pediatric palliative care doesn't mean that we stop focusing on recovery. And it needs to be multidisciplinary, including not only the treating medical team and palliative care consultation, but also child life specialists. And it is critically important to approach the family as a unit. Now, it's also different than adult palliative care. And this is one of the reasons why, particularly when you're dealing with young trauma patients and there's prognostic uncertainty, and you have to discuss that prognostic uncertainty with their surrogates, their parents, and coach them through their sibling discussion, it's probably worthwhile to engage these folks sooner rather than later, because they adjust the discussion, they adjust the approach for chronologic age and developmental stage. They acknowledge that recovery from traumatic brain injury may be greater for young patients, and there's a lot of future time for medical breakthroughs to be made. They also acknowledge that the provider distress is frequently greater, and there's often a drive to, quote, do everything, unquote, and this is not a discussion on what those set of words mean, but if there is ever a drive to be maximally supportive of patients who may have not a great prognosis, that's going to exist in young patients. So engaging your palliative care, your pediatric palliative care specialist early, acknowledging the differences, acknowledging that there's very little data, but many of the principles that we all know from adult prognostication and communication almost certainly still apply, and seeking out subspecialty consultation, because this really is, as good as we may be at talking to our patients about prognosis and supporting them through difficult times, this is a particularly difficult undertaking in the young trauma patient. So with that, I'm going to pass it over. I'm going to stop sharing my screen and pass it over to my co-presenters.
Thanks. So we're going to move on to some of the more specifics of prognostication in adults with Dr. Joyce. You are muted, Dr. Joyce.
Sorry about that.
No worries.
Stephanie Joyce from Yale School of Medicine in New Haven, Connecticut. And so we're going to be talking for the rest of the time about prognostication in the adult population and dealing with prognostic uncertainty. So I thought it was useful to talk a little bit about some severity scoring systems. How do we go about determining prognosis in adults? And when I first got asked about this talk, my mind immediately went to traumatic brain injury, because I think as trauma surgeons and surgical intensivists, I think that is where we struggle the most and where there's the most uncertainty. I think we all kind of know when a patient is bleeding in front of us, we know what the prognosis is going to be. But when we have someone who doesn't really have multi-system organ failure and they just have a severe head injury, what do we do? What is the actual prognosis? And I thought it would also be good to talk about spinal cord injuries, as we see that a lot. And then we'll finish up with prognostic uncertainty. Okay. Oh, wrong. All right. So what is prognostication? Prognostication includes the risk of death and unexpected mortality, the expectations of cognitive recovery, or other outcomes that may be important to the patient and the family. There are data scoring systems for geriatric trauma patients. We can also use NSQIP. But there's a lot of limitations, as discussed previously, when it comes to young patients. So I'm going to show you something. We can all look at this ABG, and this is a generic ABG from the trauma bay. And we look at this ABG and we know this is bad. If I don't intervene quickly, this person is going to have a poor prognosis or ultimately die. So there's information in the acute trauma that gives us a lot of guidance on how this patient is going to do. If we don't correct this quickly and rapidly, then the patient is going to ultimately die. So prognosis, initially for trauma patients, we always say that the #1 cause of hypotension in a trauma patient is bleeding. So initially for trauma patients, prognosis depends on the etiology and severity of hypovolemic shock. So we all know early bleeding source control and effective early goal-directed volume resuscitation have improved outcomes for hemorrhagic type of shock. If they are persistently in shock and they develop multi-organ system failure, we know the prognosis worsens and mortality increases. So once again, we're adept at prognosticating patients in hemorrhagic shock. But what about this patient in front of you on this screen? This is a bad CT scan. We all know that this patient likely has sustained significant head trauma based on the shift, the hematoma, but what is their prognosis? So there are actually some prognostic calculators out there to help actually specifically with patients with traumatic brain injuries. So there's the crash head injury calculator, and it calculates the risk of a 14-day mortality and risk of unfavorable outcome at 6 months. There's also the impact head injury calculator, and that prognosticates expected outcome at 6 months. Both models were externally validated with each other, but they really were based on prognostic models that combine data from clinical trials to predict a clinical outcome. We don't really have any prospective data that these prognostic calculators were based on. I threw in injury severity score in there, as that is the most commonly used calculator for determining severity of trauma. We use it in TQIP and the National Trauma Data Bank, and it correlates with morbidity, mortality, and hospitalization time after trauma. So the score can range from 1 to 75. A score of 75 is the highest. And it's broken into 3 categories. And if you get a 6 in any category, that is associated with an unsurvivable injury. So the TRACK TBI study actually came out in 2021. And it is called the Transforming Research and Clinical Knowledge in TBI. And it's a prospective longitudinal multicenter study to assess outcomes with 12-month injury follow-up post-injury. And I think this might be the largest study to date, coming from Medical College of Wisconsin, but it was a multi-center study at most level 1 trauma centers. And it followed patients from 2 weeks and up to 12 months after injury. And I was actually surprised by the results myself. Many patients demonstrated major functional gains, including recovery and independence between 2 weeks and 12 months. And I think that's really important to focus on because we don't necessarily, as providers in the ICU, see these patients at 3 months, 6 months, 12 months. And so having long-term data that we can go to is really important. And they also showed that even patients with severe impairment in the short term, it did not make it that they had poor outcomes in the long term. So a substantial number of patients actually had good functional outcomes despite having severe TBIs. So what I took away from this study was that we really need to be cautious with our statements suggesting poor outcomes in severely injured TBI patients, especially early on, because we really actually don't know, and they may actually do quite well, and a lot of them may return to work and independent living. And so I want to bring your attention, I know this is kind of a busy table, but they compare severe TBI patients and moderate TBI patients. And the 2 weeks is on the left to the 12 months. And I wanted to highlight something if this works. Here we go. So if you look at the 12 months, upwards to 50% of patients with a severe TBI have independence with traveling. And 36% of patients with a severe TBI have no deficit with social functioning. 40% have no psychological issues. So I was actually very surprised with these results that a lot of people, given a 12-month recovery, can return to some functional life after severe TBI. So the recommendations actually from the Neurocritical Care Society is that we should hold off on making profound prognostic statements before 72 hours, because we really need a 72-hour period of observation before we can even begin to really prognosticate outcomes in severely injured traumatic brain injuries. And we get a better idea of prognosis as we follow the patient, we monitor their neuro exam, and we can get greater confidence and accuracy the longer we wait, actually. I think as trauma surgeons, we're all at risk for this. So there's something called the self-fulfilling prophecy bias. And this looks at, so they scored the severity of a TBI, and that is the ICH score point. So it uses GCS, the volume of intracerebral hemorrhage, intraventricular hemorrhage. So score of 1, not bad, score of 6, really bad. And then they had providers prognosticate what they think the patient's outcome would be. And we are consistently negative as clinicians in their actual outcomes. Especially, it gets worse as the TBI gets worse. So we see a severe TBI and we automatically think that patient's going to have a poor outcome and they're not going to survive, when actually over 50% of patients survive when we think that they will expire during their hospitalization. So I take that as a moment to stop and think and really try and not rush to palliative care or withdrawal of life-sustaining treatments until we do repeated examinations and we have more confidence and we wait that 72 hours. Everybody can kind of cool off and see what the patient, let the dust settle, as we say. Now, the opposite is true actually for spinal cord injury. We actually have very good data for long-term outcomes for spinal cord injury, and it's based on the level of the injury, whether it's a complete or incomplete injury. The vast majority of patients will have motor recovery in the first 2 years, less after 2 years. We may have, I think we've all been in the situation where we've had patients with high spinal cord injuries who are complete quadriplegic, ventilator dependent, and say, I don't want to do this, I want to withdraw care. And that's not inappropriate, but there are some routes that you have to go down before you can do that. And that usually requires involvement with mental health specialists and also physicians like PM&R to give them the information, make sure that they're not having depression before they can really make that decision. The prognosis for ambulation at 1 to 2 years is listed in those numbers below. So incomplete obviously is better than complete spinal cord injury, and paraplegia is usually associated with better outcomes than either tetraplegia or quadriplegia. And you can see the lower the injury, the more functionality patients have, but that's inherent to the injury. So how do we deal with prognostic uncertainty? I gave you these scoring tools, but even they don't really help us when we're sitting in our family meeting with the patients and their family members and their loved ones, and they say, is my loved one ever going to wake up again? Are they ever going to walk again? Are they going to have live a normal life? And that's really hard to say. But there are some ways to deal with that. So, like I mentioned before, but I just kind of want to reiterate it, because the first 72 hours, we really shouldn't be making a decision. But despite this, recommendations from the Neurocritical Care Society, up to 50% of decisions to withhold or withdraw treatment occur within the first 72 hours. And I think that's because as providers, there's this perceived need that we have to make a decision quickly because we want to avoid prolonged suffering in these patients. And we also want to avoid getting to that point where, you know, they're sickest within the first 72 hours. So if we withdraw these measures, these life-sustaining measures, they will likely pass quickly and in our minds painlessly. And if we get beyond those, they kind of stabilize out. And then we're in a long, protracted course. And we feel as providers that we may be harming the patient or causing them undue suffering if we get to that point. And so I think that's why a lot of this happens, is we're acting in what we think is the best interest. And it's hard. It's not, none of this is easy. And we face a dilemma. We can provide treatments that allow patient to make a good functional recovery. But we can withhold treatment, ensure that the patient will not be trapped in a state that is unacceptable to them. And so it really is sometimes between a rock and a hard place, a moral dilemma for us as providers. Just to focus on that. When prognosis is uncertain and the prior wishes of the patient are unclear, it is appropriate to provide aggressive treatment. We can't make assumptions. If we don't know, particularly in younger patients, I think it's a little different in elderly patients. But if we don't know what the patient's wishes are, and we're not really certain of what the prognosis is going to be, then really it's appropriate to just do full court press, full steam ahead, and be as aggressive as we can. So, and being aggressive can improve outcomes. You know, we all know this by now, but we always want to avoid secondary brain injury. So hypotension, hypoxia, you can see them listed below, but we want to avoid that secondary insult to improve outcomes. And that's what I mean by early aggressive treatment. And there's benefits to that. We maximize the probability of an acceptable recovery, and we can help increase certainty regarding prognosis. If we do everything and in 72 hours or a week or 2 weeks, the patient isn't waking up, I think it gives you more certainty when you go to the family and you present the situation to them and you can say, hey, we did everything we could possibly do for your loved one, and they have made no neurologic recovery. And that makes it maybe easier for the family to accept that everything was done and they can possibly let their loved one go. Or we can say, you know, they haven't made any improvement. We don't think they're going to improve. However, it does have risks. It's very invasive, and what we do isn't pleasant for the patient, particularly if they have if they're not in a comatose situation. It's also traumatic for the family members to see their loved ones like that. You know, we talk about post-traumatic stress disorder. You know, we could be contributing to PTSD for family members when they see their loved ones like this. It can take several weeks before we're confident in the prognosis of the patient. And so, i.e., we are prolonging their suffering. And to look at it, we are utilizing a lot of resources on an already strained healthcare system on someone that we're really not certain is going to have any survivability. So why do we have uncertainty? Well, we really don't have good quality prognostic markers. Now, I did, say earlier there was tools for prognostication, But I also mentioned that those are really pulled from data with no prospective evaluation. And they are kind of behind the times always. So they're not really reflecting current technology, advances, updated practices. So it's really hard for us to say how well someone's going to do. But we do know there's some poor prognostic factors. So the older you are, the sex, cause of injury, GCS upon presentation, pupil reactivity, CT findings, size of hematoma. But despite all of that, you can have a young patient with a GCS3, minimal pupil reactives, and a horrible CT scan, and they can go home and be with their family. So even the poorest prognostic factors that we know still does not put people in a box that we can wrap with a bow and say, this person is going to have a horrible prognosis, because we really we don't know. So decisions to withhold or withdraw life-sustaining treatment are strongly influenced by the clinician's own beliefs, values, and practice style. I think everybody approaches it differently. We all have our own feelings on the matter. And one of the strongest predictors of withdrawal of life-sustaining treatment is the view that severe disability is likely to result from continued care. But like I said before, we tend to be overly pessimistic when assessing prognosis. So we really want to avoid that self-fulfilling prophecy as much as we can. So when do we decide prognosis? Or when are we starting to decide? One strategy is you want to wait. So wait at least 72 hours. You really shouldn't be making those statements unless it's, herniation, brainstem, brain matter coming out on the bed. But for severe TBIs and even moderate TBIs, we really should be waiting 72 hours before considering withdrawal of life-sustaining treatments. However, if the patient's condition continues to deteriorate during that period within those 72 hours, then it's appropriate to begin further palliative care discussions. But don't feel pressured by that window of opportunity where they're really, really sick, and that if you have withdrawal of life-sustaining treatment, they will go very quickly and they're not going to have a prolonged, protracted course. Don't feel confined or boxed by that. You really should just take a step back and wait. Talk with your colleagues in the neuro ICU, your neurosurgeons, your neurologist, and really kind of come up with a plan. I wanted to put one blurb in here about persistent vegetative state, because despite us having family conversations about poor prognosis, there are some times where patients' family members absolutely refuse to withdraw, and the patient is left in a persistent vegetative state. So there's no diagnostic test that we can use that confirms that there is a disorder of consciousness is permanent. We have neuroimaging, but we have no way to tell whether someone's ever going to wake up from a persistent vegetative state. However, there's a multi-society task force that estimated the chance of recovery. If they've been in it for less than 3 months, their chance of waking up is 33%. 3 to 6 months is 13%, and 6 to 12 months is at 6%. So the longer that they are in a persistent vegetative state, the more likely they are to remain in a persistent vegetative state. And 19% of patients are diagnosed as being in a vegetative state can demonstrate awareness through functional neuroimaging. And so there's always a possibility that, doing neuroimaging at the 3-month mark, 6-month mark may help family members make a decision. And sometimes it unfortunately takes that long. But that's really difficult at times. And a lot of the times these patients will be transferred to long-term care facilities. And so as providers, we don't necessarily get exposure to that all the time. So, thank you.
Great, thank you. Thank you so much. We're going to open things up for questions, and I'd like to get started. Dr. Cook, if you don't mind, could you walk us through how you would communicate a best case, worst case scenario to either a pediatric patient and their family or an adult patient, your choice?
Yeah, certainly. And I certainly want to emphasize that this is work that's done by a lot of, the original work in this is done by a lot of people other than myself. And I've read their papers and I've taken their training, and I believe deeply in this, but it is certainly not my own idea. The concept here, and there's a really great, the University of Wisconsin website has a really great short video on it as well, is we don't know the future, right? But we do know, with some capability, we do know the bounds of what the future may hold, right? If you are 85 and you suffer a severe traumatic brain injury, it is probably not in the cards that you're going to walk out of the hospital tomorrow, right? And so when I am personally a fan of what's suggested in the Patient Communication Project, which is you start with a blank piece of paper and you draw a line starting with a square and going to a star that starts with the worst case that you can possibly imagine, ends up with the best case that you could possibly imagine. And now what those worst case and the best case are really are dependent upon what's important to the patient. Sometimes it includes pain and suffering, sometimes it includes return to function, sometimes it includes time away from work and loved ones. But the best and the worst case get framed as the stories that are pertinent to the patients. Yeah, that perfect, that one. Yeah, and truly anyone who is watching and wants to learn more, I would direct you to there, because the folks who've originated this did a ton of great work. And then you acknowledge that, yeah, I have a sense of what's potentially possible. And also, given the fact that I've been doing this for some large portion of my adult life, here's what I think the most likely outcome is from where we are right now. And again, that gets framed not necessarily as statistics, because patients struggle to engage with statistics, but it gets framed as stories and values. And if you do it in real time and then have the piece of paper to give to the patients afterwards, they can kind of, it makes it a little bit easier for them to wrap their heads around it. But I do very much start with a blank piece of paper and draw as I talk.
Great, thanks. Any questions from the group? You can unmute yourself to speak or ask in the chat. Otherwise, I was wondering, Dr. Joyce, when I was looking at your slide, on the persistent vegetative state and saw the 6% after, I think it was 6 to 12 months. And I was just wondering how you discuss with the family who says, hey, 6%, there's still a chance. How do you deal with that question and handle questions in the single-digit percent range that represent, a substantial source of hope for a family?
Yeah, it's always really hard when people latch on to like a number, even if it's a really small number, particularly with the 12-month persistent vegetative state. Really at that point of time, the patient's going to be experiencing a lot of other complications. Like a lot of these patients come in with infected sacral decubes, frequent pneumonias. And so I wouldn't really kind of focus on that 6% of them waking up, but I would focus on what their quality of life is right at that moment. I had a very interesting case where a patient had an anoxic brain injury from a code, and the family was very much, we're going to do everything, and their religious views said they were going to have a miracle and they were going to wake up, and we couldn't talk them out of it. So he got a trach and he got a peg and he was on dialysis, and he wound up getting a we kept getting consulted on him for sacral decubitus, and finally we brought the family, because they wouldn't come to the bedside. We brought the family in and we had them look at everything we were doing. We had them look at the decubitus and the care involved. And I think at that point, they realized what they were putting their family member through. And I think there's a lot to be said about showing everything that we have to do to sustain these life-sustaining treatments. And when the family members actually see what's involved, they wouldn't want to put their loved one through that. And that's, I think, a good way of kind of overcoming that barrier.
Great, thanks so much. I see a raised hand. I'm sorry, I don't know your
Hi,
designation.
that's
Go
okay.
ahead.
Jessica Stazak. I am practice in St. Louis. Just so you know, also the chat says disabled for me, so I don't know if other people were trying to type questions, but we can't. My question, and I apologize if I missed this, but do you have any tips for sort of initiating discussion with families about kind of really deep thinking about what their loved ones would actually want? Because in some of these, especially pediatric patients or really younger people, I think it's hard to get them out of their grief and thinking about what somebody who they've never had that discussion with might want. So how do you initiate those discussions and sort of impress upon them what, how to think for their loved one, I guess?
I don't mind starting with that. I mean, and I think I usually try and start with asking them what their understanding of the situation is, so that you can kind of get a baseline of where they're at. And it's really helpful if you get them to talk about what they were like before the incident, and see if you can kind of get to the root of like what their goals for life were, or things like that. And then I usually kind of paint the picture of like, the best case scenario is this, and then this is the worst case scenario. And they can fall anywhere in between. And I ask them to go home and I think about where is it unacceptable for you? Like in the spectrum of best case scenario to worst case scenario, where is your line in the sand where you're like, I can't do this for my loved one. Like this is not cohesive with what their life was like. And I know that they would never be okay with this, and really get them to have introspection on that. And I find that's helpful.
Yeah, I totally agree. I think one thing I would add is that this is often not something that's going to be accomplished in one conversation. And one of the first questions I usually ask is, what is your understanding of so-and-so's health, especially in elderly patients? Because that really reflects a lot on the family's perception of their health, whether it may be what their health is like or not. It represents, their point of view. And if their perspective is that mom was completely independent and healthy, and this is very sudden, I feel like then you're starting mainly probably with an information sharing family meeting, and that it's going to require several subsequent family meetings, even to start talking about pathways and treatment, and not bringing my own expectations to the meeting of we have to, make the patient DNR, or, some things that might be on some providers' agenda. But thank you for the question. Any other questions from the group?
I would just highlight for the participants, Dr. Clark put in a comment in the questions and answers about there's a podcast on the surgical palliative care, or there's an episode of the surgical palliative care podcast with Dr. Hoffman and Dr. Schwarze that's all about the best case, worst case tool. I put the link in there, and is super helpful.